of Health for Inclusive Growth. Today is Health Tech, and the theme is Tech for Saving Lives. And the first session of day 2 today is a focus on achieving equity with telehealth. This session is being chaired by Dr. Rana Mehta, partner and healthcare leader, PricewaterhouseCoopers Private Limited. And we have also with us Mr. Anirban Lahiri, founder, Medica, Vietnam. Mr. Suresh Ramu, co-founder and CEO, SiteCare Hospitals Private Limited. Mr. Partho Chakraborty, Chief Scientific Officer and Board Member, Arogya Medisoft Solution Private Limited. They are also an incubator of the Webel BCC&I Tech Incubation Center, which the Bengal Chamber has set up with Government of West Bengal's IT&E department. So here I request Dr. Rana Mehta to please take the session forward.
Thank you, and thank you. It's been a pleasure being at the Bengal Chamber for many years, and really do appreciate how you're bringing the whole inclusive growth agenda in healthcare to the forefront. And I thank all the panelists for coming in and look forward to this session. I think a lot has changed, while we speak about telehealth. I think something like telemedicine existed for over 5 decades, but generally got very, very little traction as such. While I think the initial telehealth was, over a phone line, but it really failed to grow because I think while the technology was there, probably never had the business model. And in many ways, the pandemic actually catalyzed the business model because this is the first time we actually saw that a healthcare crisis caused an economic meltdown. Previously, whenever we've had an economic meltdown, either it's a financial crisis in the stock market, it's a war, it's a natural calamity, but never have we experienced a healthcare crisis. And a very humble assailant, a virus which borders between the living and the non-living. And we're not through the pandemic yet. We've seen exponential growth, but very slow declines. Many countries in Europe are having a 4th wave, 5th wave. I think by the time the pandemic's over, we may have learned the whole Greek alphabet, but I hope not. I think it also demonstrated that there were clear winners and there were clear losers in the pandemic. Who actually won? The winners were actually the technology companies, and you saw them really grow big. Who lost? Where mobility was important, and that was where the healthcare providers. When you had a lockdown, there's no way you can run an outpatient department. And you suddenly found that all you did was acute episodic care, and you did not play across the continuum of care. So I think a lot of lessons which happened. And I think in India also we saw that the tier 2, tier 3 cities where people generally tend to go to the larger urban conglomerates, they found that they had to take care there, and the quality of care is now improving across because India is very skewed. You have 70% of your healthcare infrastructure just limited to 20 cities. Also, I think one of the most positive parts, I think, is it really brought up the question, who's responsible for your care? Is the government responsible, or are you responsible, or is your insurance company? But I think the great thing is both nationally and internationally, healthcare has become part of the national discourse. And some of the questions which were never addressed, what's the business of healthcare? Is it keep making sick people better or keeping people healthy? Is the visit model actually necessary? Do you need to go to a tertiary care hospital for a cough and cold? How you can move to a high to a low? I mean, people would never imagine that you could set up an ICU at home, but it all happened. And finally, for a payer perspective, it was about value and not volume-based, because we look at healthcare as about 3 things. It's about infrastructure, process, and outcomes. But the outcomes are very less dwelt on. I think the accessibility to healthcare, both in India and most of the developing world, is limited by affordability. I think bringing this equity, technology played a big part. And I think one of the biggest components is, when you go to an ATM to withdraw money, it doesn't matter whether you're the president of the country or, you're just a menial laborer. It treats you in the same manner. And one of the good examples when we did a telemedicine study a couple of months ago, so one of the patients told me, I used to go to this hospital and it's a diabetic patient. The doctor would just see me for 5 minutes, and this has happened for 15 years. When I went on a telecall with him, he had to spend 15 minutes with it. I thank telemedicine for this. So there's been a very positive impact. So Anirban, I'll go to you straight away. And I think, like I said, accessibility limited by affordability. But in the developing world, I think the supply side issues become very, very important. And how can telemedicine really address the supply as it moves towards making it more equitable?
Sure. Thank you for hosting me here, and let me try my best to address your question. I think that telehealth, in the conventional sense, and generally the use of information and communication technology in healthcare delivery, has focused more on bridging the divide between care providers and patients. In a very conventional sense, how do you improve access to healthcare for the patients themselves, particularly in situations where the patient resides in a particular region of the country that does not have a very good brick and mortar infrastructure, medical expertise. But I think that telemedicine or telehealth has far broader application, as you mentioned, in terms of improving the supply side aspects. And here, I think one thing policymakers should really be thinking about in India and other developing countries is how do you use that same information and communication technology, which has so far been, focused on to bridge the divide between patient and provider. How do you use that same infrastructure and technology to empower the practitioners of medicine or the providers of healthcare in these more remote areas, tier 2, tier 3 cities, etc., in the country? And so the way to do that really is to connect the doctors, nurses, and other healthcare practitioners in these more remote parts of the country, outside of the major medical hubs or centers of excellence, to their counterparts in the major medical centers of excellence for case sharing, second opinions, and just plain and simple knowledge transfer. So to answer your question in a nutshell, I think it's really about education. Medicine is an empirical science. It's continuously evolving. And you could be a gold medalist, or theoretically, or in your academic life, you could have been the best in your class, at top of your class. But if you don't have a continuous flow of new information, scientific knowledge, you become obsolete. And so I think continuing education is even more important in the field of medicine than it is in other fields like law or other professional occupations like engineering. And in that sense, if you want to really improve the quality of healthcare outside, in the hinterland, so to speak, you really have to focus on creating an infrastructure for continuous delivery of that up-to-date sort of medical scientific knowledge, best practices, and clinical guidelines to the healthcare practitioners. And in the process, you're essentially bringing high-quality healthcare to the patient population in those regions, but rooted through the practitioners that reside in that particular region.
I think a very valid point, and it also gives us a real opportunity to increase the quality of the care delivered, right? Because with telemedicine, I mean, the whole idea is how can you make a virtual care experience equal or maybe even superior to that? And given technology, a doctor now can actually, he's prompted on screen to look at vitals. It's pretty much running through a checklist, like a pilot runs through a checklist before he takes the flight off. So I think the capture of data is much stronger. Otherwise, it's very incidental. Going back to the diabetes example, you just look at you, say, okay, your blood sugar is fine, continue. But you may have kidney failure, and he's not checked that out. So I think what you rightly said, it also, besides democratizing it, has the potential to really, because the doctor becomes more accountable, because at some stage you're able to also record that conversation. Right. Thanks. And
if I may add,
Suresh, moving to you, I think one of the things we saw within the pandemic with mobility yeah, sure, go ahead.
Sorry, there's a big time lag here. I just wanted to add one more thing, is that in developing countries like India, typically you tend to have a trust deficit, right? And this is particularly acute in more remote areas outside the major urban areas where people tend to be more open-minded and more in tune with the latest technology. So if you go to a tier 2 or tier 3 city in India and you tell a patient that you can actually get online with a doctor sitting in Mumbai or Delhi or Chennai and get high quality care, it takes a huge mindset shift for the patient to actually accept that. And so there's still an emphasis on physical interaction in the flesh, and visiting a doctor physically carries a certain perception of, I guess, higher quality than a pure online consultation. In that sense, also, when we talk about empowering the supply side, it's also a question of not trying to be too ambitious in terms of changing patient behavior overnight, but rather working in a manner where you use technology, but you still provide a physical experience to the patient. And hence, you need a sort of triad where you have a doctor who's truly a KOL or an expert in his field residing in a major medical hub or urban center. And then you have the local doctor or nurse practitioner where the patient is in that tier 2 or tier 3 city, and the three of them work together to address the patient's need. That way, the patient benefits from the expertise that is not available locally through the remote connection with the senior doctor, but he also gets a face-to-face interaction with the local doctor where he's residing. And that together is a much easier and more acceptable solution, in my view, than jumping from no doctor to a pure remote consultation with a doctor sitting thousands of kilometers away in a different city.
Yeah, I think the whole process is going to be more evolutionary. I think while the pandemic showed it's possible, but I think the cultural shift, and I'll actually come back to you on that, Nick, in the next round. Suresh, one of the things we really found that, when mobility stopped, your method of patient acquisition was very, very different. The need for a digital healthcare platform came in place. If you look at the companies which did best, which had mobility, like the diagnostic companies, the e-pharmacies, how do you see the shift as we go ahead, with a little special emphasis on oncology and how that's going to pan out?
Yeah, so what Anirban was saying, I would just like to take off from there. I was part of a telemedicine startup company way back in the year 99, 2000. Which is obviously too early for its time to look back. And there was a business model embedded, but there were cultural issues, there was technology issues in terms of transmitting volumes of data. I think we've come a long way today. If you see from the availability of technology and the adoption of it, there was still a trigger pending in terms of the need to do it rather than actually meet the doctor physically. I think it was both from a supplier, that is from a doctor perspective, and also from a patient perspective, that they always preferred the physical interaction. I think things have obviously changed in the last 1.5 years dramatically because of a forced need, so to speak. When you look at oncology, you're looking at life cycle management or the entire continuum of care, right from where do I go? I'm suspecting something. Whom do I meet, or how do I get this reviewed, to diagnostics, to treatment, and to post-treatment follow-up. In our own hospital, in a cancer setup, and for advanced surgeries, the post-treatment follow-up was the first thing that automatically moved to consultations and video consultation. That was the immediate shift that was almost instantaneous. And today, even if people can come to the hospital, we have a lot of people who say, let's just do a follow-up online. So that is, and because there is a payment model and both parties are now comfortable getting this consultation, and sometimes it's actually better, as we discussed, than a physical consult in terms of time duration, I think everybody is happy with a post follow-up. The acquisition or the selection of where to go for treatment also has moved significantly to digital. So which means people are sourcing, they are searching before they visit the hospital. Even if they know the name of the hospital, the brand name of the hospital, they want to look up who the doctor is. They want to understand the credentials. They're looking up ratings of doctors, which was there earlier, but now there is a lot more active digital involvement. And we see a lot of tier 2, tier 3 patients as well, apart from international patients. And tier 2, tier 3, if you look at the adoption on the supply chain side, e-pharmacy side, and even a grocery side, and even goods that are being ordered online, you will know from the big that in India, a significant component percentage of the total volume comes from tier 2, tier 3 cities as compared to even urban. So, and we see the same in oncology. We see a large amount of participation from tier 2, tier 3 digitally by patients themselves before they arrive at the hospital. The big piece is, of course, diagnostics. A lot of this cannot be done remotely, and patients have to come. And we are seeing a huge delay and a time lag between the consultation and the actual physical diagnostics. Sometimes you have to do a CT scan, you have to do a biopsy, you have to do, and that is getting significantly delayed, leading to late stage advanced diseases that we are seeing. And that is really unfortunate. Treatment itself, a lot of it is and will continue to be physical. And I don't think a lot is digitally possible. Surgery, radiation. A lot of the chemotherapies have moved through infusion pumps and on at-home services, but still a lot, I would say 90%, 95% is still in hospital-like setup. There are models emerging in terms of near home, at home, if not at home, then near home kind of outreach daycare centers. And that model, I think, will continue to expand given the fact that patients prefer to get treatment nearby. We have also got a tele-ICU setup in site care, which has been extraordinarily successful. And we launched it actually about a year and a half before the pandemic. And at that time, it was obviously like fancy stuff. But we wanted to do it because we wanted to improve the quality of the intensive care, because you get round-the-clock cover with senior intensivists from a command center, better than having junior intensivists on a Saturday evening, and on-call senior intensivist. So that's something that we've been very successful along with a company that we partnered with. And post-treatment follow-up, as I said, continues to evolve and improve. A lot of devices are now beginning to be available, but the adoption there is still much slower than I would like to.
Yeah, and I think a very valid point, and also I think in oncology, if you to look at any specialty, the sheer number of manpower really is very low compared to what the potential problem for us is, and given all the medical education, that's not significantly going to improve in a decade. So how can we distribute it and utilize it better? I think some of those building blocks you actually put into place, right up from the follow-up to looking at intensive care, which in oncology also tends to be protracted and much more complex.
Yeah, no, the compliance to care is a very significant part of the management of patients. And I think tele consultations allows for that. I think that is the big plus that I see. Patients can be guided, can be told when to come, when not to come. A lot of medication can be given locally if they know what has to be done, etc. So we are seeing actually a much better level of follow-up care that can be delivered through telehealth.
Thanks. Parthu, I think, while we're talking about telehealth and we, associate that a lot with virtual care, whether you connect with the doctor over an email, over a phone, or you have a video call. But I think you've gone one step further and you try to build actually a telehealth platform with, all, so that it is much, much more comprehensive. And this is being done globally. What are some of the experiences you've seen as you build this up? And how do you think the model would be appropriate to scale up in India?
Yeah, so what we were focusing in with Arogam Medisub solution is that to look into the 70 to 80 crores of Indian who live beyond the urban setup or the tier 2, tier 3 setups, and who get basically a very minimal amount of primary health care through the different health center and sub-centers which are operated by the government or the different non-government setups. So, and many of these, say, I would say that in India, around 200,000 such centers are there who operate in a very low tech uh, infrastructure. So that means when in many of these setups, when the patients come, and there is hardly any equipments which can take the patient's minimal amount of vital information, physical examinations, and say routine checkup of blood and urine. And then, of course, that itself gets difficult, and getting an access to a physician is even more difficult. So, first of all, what we understood in through our experience, that if we connect the physician with the patients, even in the remote setup, but through video conferences and etc., it becomes difficult for the physician to do a real consultation, because the patient's many of the parameters is not known to them. And in remote and rural setup, another issue is that if doctor actually tells that please perform this test and come to me after some days, many of these patients do not again appear back into the these setups. So, and that also very much linked to their livelihood, because once they come to these setups, it is actually loss of their livelihood. 1 or 2% livelihood is lost. So we thought of actually bridging this gap by creating a telehealth platform, which in one way is very similar to any other telemedicine platform, by which a doctor will be able to see the patient and issue the prescriptions and etc. But at the same time, from the other side, patient's heart and chest sound will be transmitted to the doctor on real time. Then patients' different other vitals and the ECG will be can be sent to the doctor on the real time. And different vitals means temperature, blood pressure, and SpO2, and there are some other parameters are there. And along with that, some of the basic routine blood and urine parameters, for example, hemoglobin, blood glucose, cholesterol, triglyceride, bilirubin, and which encompasses basic routine checks on the say 5 vital organs, that will be transmitted to the doctor on a near real-time basis. So in that sense, within a 30 minutes of time, a physician gets up all the primary information of the patient with an aid of a nurse at the low-tech setup, and eventually can issue a prescription, and the drug can be, the medicine can be dispensed. And we see that this model is gradually evolving, and not only us, there are a few other players are also working in this model and try to actually help the setups throughout the India, and also we see that thing happening in the Latin America and Africa as well.
No, I think that's been very exciting. I think it's like just like telemedicine. I think the platforms have been tried before, but I think the success will be looking at a replicable, scalable business model which is viable, because many of them have depended on grants to grow. But initially, those can only be temporary when the patient starts paying. And in India, we know 65% of the payment is out of pocket, or there is an insurance provider, because insurance in India is still very acute episodic care insurance. We really don't cover outpatient, or post-operative also gets covered for a short period of time. But I think as the payment goes across the spectrum of care, I think the platforms will play a much stronger role.
That's true.
Coming back to you, Anirban, I think one of the things we also, like we said, the whole idea of technology to empower the doctors. One is, how do you empower the doctors? And the second, which you alluded to, and maybe you can detail now, is how do you change the perception and the consumer behavior? Because that's important. Like we always say, technology is the answer to everything, but sometimes you've got to know what is the actual question.
Sure. I think Suresh actually alluded to this because he said that in some senses, behavioral changes which would have taken a decade to play out have been compressed into a span of a couple of years because necessity is the mother of invention and adoption in some senses. So if patients had no option to physically travel and visit a doctor, all they could do really was consult the doctor online. So in some senses, COVID has helped accelerate that change in mindsets and patient behavior. But I feel that once the situation is abated, I don't think you're going to see this as the new normal necessarily. I think some elements of that behavior, some openness to using technology to consult a doctor will stay. But I think in some senses, people will want to go back and revert back to their old habits and behavior of consulting a doctor physically. And I think one point that was just mentioned recently is quite pertinent. In my experience, and this is not just in India, but in other countries, developing countries as well, where the population tends to be somewhat price sensitive and out of pocket expenses are a significant portion of the total, medical bill. I think people tend to be very sensitive to value. And there's a perception, that you get real value when you visit a doctor physically, and you don't get the same degree of you don't get the same value when you're consulting a doctor virtually. Now, the problem really is one of economics, because as long as you have government grants and subsidies, it works well. The minute that you need to go back to a market pricing mechanism, what happens is, from a doctor's perspective, remember India and several other developing countries like India have a shortage of doctors, right? Our doctor to population ratio is well below what is considered by the WHO to be sort of, the minimum level that you need to deliver an adequate quality of healthcare to your population. So in supply constrained countries like India, doctors are already busy, right? An average doctor has a very high patient load. He's not idle. For a doctor, if he's going to spend that 10 minutes or 15 minutes consulting a patient virtually versus seeing a patient physically, he's going to think about the opportunity cost of his time. He's not going to say that I'll charge less because this is a remote consultation vis-a-vis a physical consultation. But from a patient's perspective, somehow it's hard to stomach that I'm going to pay the same amount or close to the same amount to consult a doctor online, versus actually going physically and meeting the doctor, right? So that's where the real behavioral and the perception problem lies, because the perceived value is going to be much lower, and you're not going to have a big price differential unless you have unique business models where the teleconsultations are used as sort of loss leaders or patient acquisition techniques to ultimately culminate in patient traffic to the hospital. And therefore, if you look at the customer lifetime value, it still makes sense to have a subsidized rate of teleconsultations. So I think to answer your question, I think the first thing you really need is to design the pricing and develop the pricing in a manner where you overcome that barrier where the perceived value is just not there in a virtual consultation. And I think the second thing really is, I firmly believe that even if you have most of the consultation, the diagnostics, everything, even if that's done virtually, it's important for the patient to know that there is somebody in the flesh they can go to if things don't go according to plan. I mean, ultimately, we're talking about health, right? When I go to a doctor and I consult him, particularly if it's something critical, I want to know that if things go terribly wrong, I can walk into his clinic tomorrow and ask him what happened and seek alternatives. That's much harder to do in a remote setting because the perceived accountability of the provider is far less than in a physical setting. So having an option and saying, okay, this is your teleconsultation doctor, but we have a triad and you have a local doctor or a nurse practitioner or an internist sitting in your area who you can go to if you have a problem. And that problem can then be escalated again to the senior doctor sitting a couple of thousand kilometers away in a major hospital in an urban center. that itself, I think, will help change perception because it seems to be less risky for the patient and creates a perception of greater accountability. And secondly, it addresses that perception of that, the lower value you get when you're consulting a doctor physically and paying a comparable fee to what you would, when you're consulting the doctor virtually and paying a fee that is comparable to what you would pay the doctor in a physical consultation. So pricing and having a sort of offline alternative of point of contact where the patient resides, I think are key elements to changing or to altering perceptions. And I think the thing after that really is really about creating successful case studies. If you have several examples of patients, particularly with complex critical conditions who were successfully treated, and that knowledge is somehow disseminated to people, I think that itself will go a long way. So patient education is important as well. When we talk about education, it's not just doctor education. Patient education is also vital to altering perceptions.
I think that's very important. And I think rather than an individual, like you rightly said, an ecosystem approach to make sure, you take
Exactly.
all the areas, all the touch points, encourages a patient to say that, this you'll get equal value. And over a period of time, obviously, from an economic point of view, there should be no difference between a virtual consult and a physical consult. And I'm sure that
in fact, I would
happen.
say that there's even a case to be made, ultimately, if you can communicate this effectively, that a virtual consultation could deliver certain benefits over and above a physical consultation. For example, a system of continued monitoring, having all your data stored in one online repository in the cloud, easily accessible by your doctor, your nurse, or the doctor who's consulting you remotely. I think there are certain elements of a virtual consultation and certain benefits over and above a physical consultation that can actually be highlighted. For example, if a patient, as one of the panelists mentioned, if you have a remote monitoring device, which is continuously reading in real time your heart rate, and you have a heart problem, let's say you have cardiac arrhythmia, and then suddenly you have an instance where you have very irregular heartbeats for a certain period of time, and there's an automatic alert which can be sent by SMS to your doctor who you consulted remotely. That in some senses is even more valuable than having a physical interaction because that option might not be necessarily available, right? So I think it's really not just about saying that a virtual consultation is equal to a physical consultation, but there are elements of a virtual consultation that go even above physical consultations in terms of creating value for the patient.
Yeah, and I think in many of the emerging markets, we don't have an option, right? You'll probably never have first enough doctors, enough hospital beds. The financial access is also going to be poor. So I think the technological access needs to be actually promoted by the government and the private sector because, it's better to have that access rather than have no access at all. And over a period of time, like we've seen in the banking sector, and India is a good example of the UPI. You can even pay the greengrocer on the road with your Google Pay. And so I think there is an acceptance of technology where people have started relying and saying, technology makes things transparent, and maybe healthcare can ride that wave.
Suresh, and there's a digital trail.
Yeah, exactly. So I think the transparency and the trust part also become very important. So if you prescribe something, you're accountable, and that's where when you become more accountable, I think the whole quality goes up. So technology, more democratic, accountable, and then it becomes more accessible because you could access it anytime. Suresh, we're getting a lot of questions from the audience, and I'll start with you on one. Is technology making healthcare more expensive? What do you see is the approach to balance cost and advanced technology? And I think this is also critical, especially in the oncology arena.
Oh, I think, from a patient perspective, I think what is happening is patients were always trying to, the urban consumer particularly, but also I think when we are seeing people coming in from semi-urban areas into super specialty requirements like we have at site care, patients wanted multiple opinions they're seeking second opinions and then making major decisions like a surgery or going down a path of treatment. And I think that tele consultation, video consultation access has dramatically increased the number of second opinions that patients are taking. And I think that has a direct impact also in terms of revalidating the cost of treatments that they are getting. So, both in terms of diagnostics as well as in terms of treatment, cost of healthcare from a patient perspective has not, I don't believe, has actually increased. I think the choices have increased. People are becoming far more aware, and we definitely see that patients coming in will almost always have a couple of opinions, and we encourage that actively from a patient perspective to say that you need to have. Internally, we have a multidisciplinary approach already, but I think from a patient perspective, they want to also revalidate that. So a lot of the costs are capped in a variety of different ways in an Indian kind of setting. The government schemes, of course, have already capped the prices of treatments. And in fact, a lot of the treatments have become lower in cost because of caps on the implants, etc. If you look at insurance, a large component of the paying patients are becoming more and more insured, and the value of the insurance cover is also increased. I think people have now beginning to recognize the need for higher value of insurance coverage, though it is still much, much lower than desired. But I think there is greater awareness. Again, insurance drives the price ceilings on a lot of the procedures that a hospital would do. Unless there is co-pay and the patient is willing to pay, you're not seeing a dramatic increase in terms of actual payment to the hospital itself. So I hope that answers the question on the price increase. I think technology per se is actually to improve efficiencies. So if you think about accessing a senior specialist sitting in Mumbai today, you could do that sitting at at Jalgaon or in Mysore, and you don't have to travel as much, and you can get a first-rate opinion online, and then you decide whether you want to go to Mumbai and actually take that treatment, right? So I think in many ways you're optimizing cost of travel, cost of accommodation, because you've already set up a lot of things prior to your travel. And we actively see that it is reducing the overall reduction in life cycle value of treatment.
I think that's really important, and I think the way technology can also scale it up, because while we've been doing healthcare in India for 75 years, the outcomes at some stage are still very suboptimal. So and it's not that we can pick up another model like the NHS, because you just don't have enough taxpayers to fund that. So I think we need to have, which again has technology at its core. And I think the whole idea of the National Health Authority is, again, to predominantly put in the building blocks for a technological access to care. Partha, we got a question from the audience, which I think is very appropriate. So as you really put this startup together, what were some of the challenges within the ecosystem you faced? Now, we spoke about two challenges. One is the cultural and the acceptability challenge. One is the financial model, the business model challenge. But what were the other challenges you faced? And especially if you were to look from a regulatory point and say that, if you were to fast track healthcare platforms like yours, what would be desirable?
So there are, I think, I will say, let me answer in a different way, that in last 5 years, there has been several changes in the regulation of healthcare, medical devices, telemedicine within India. For example, before 2020 March, that means when COVID set in, there is no formal law or regulations for telemedicine in India. So it was always a issue that whether telemedicine is illegal or not. So that is one of the challenges. It was definitely there, but that has been all now cast in stone by the law passed in the parliaments. Secondly, is a very important thing. When the startups are making the devices in India, made in India devices, then there was no regulatory framework which was existing in India. Again, that actually has been corrected since 2017. 2017 and 2018, there is a new law has been passed, a new regulation is there. Now, it is not, it is actually Indian startups can actually create their own device and get it tested in India and get it certified by the CDSCO, which is a drug controller equivalent of US FDA in India, and now market it in India without any issue. So there was definitely some challenges, but the challenges are is being, I think, proactively addressed by the government also as well in terms of the regulations and etc. And the overall awareness and etc. needs to also go up in this matter. So that is definitely, I think, will happen with the time.
No, I think a very conducive regulatory environment is required, right? We saw when it came to, Indian IT, there was an absence of regulation, but there was always a light touch, and you let the industry grow, and then make sure that you do regulate from a consumer point of view where it impacts, so you don't really choke the system, but build in the safeguards. Anirban, the next question which has come, I think. Is that one that while we've been talking about the whole direct to patient through telehealth, but one of the biggest problems in any developing country is upskilling the healthcare resources, because that and like Suresh had also mentioned, everything gets dated after a period of time, so the skill sets on ground tend to be weak. And how can telemedicine actually be used for that?
So I think telemedicine can be used in two ways, and I wouldn't say telemedicine in the traditional sense, but basically using ICT for medical purposes. And I think one of the ways to do that really is the obvious one, which is creating information content portals, CME. For instance, today, if you want to participate in continuing medical education courses, you have to travel physically to a CME event, typically held in bigger cities. You have to physically be there, right? In many countries, COVID has made policymakers loosen up here their requirements, so you can participate in a CME course virtually. So if I have a company, a pharmaceutical company with KOL doctors in the field of respiratory medicine, talking about best practices in management of asthma or chronic obstructive pulmonary disease, I actually do not need to travel physically to that place, spend time and a couple of days in a hotel. I can attend it virtually and get rewarded. So that's one way of doing it. It's really about using the internet to allow for dissemination of educational content, whether it's events, webinars, research papers, etc. The second thing is what I alluded to before, is really creating a infrastructure for doctors or practitioners in these more remote, under-resourced areas to directly engage with their counterparts who are much more senior, much more experienced in the big cities and have access to state-of-the-art technology. And the way to do that is really to allow them to share cases, right? So it could be that a doctor, let's say in Bhubaneswar, is dealing with a complex case of, I don't know, complications of tuberculosis, which has probably gone to the brain, etc. He doesn't really know what to do, right? He can actually go into this shared space or this community space, publish the case, and invite opinions from experts in the field sitting maybe in Kolkata or other parts of the country who have seen those kinds of cases before. The tragedy really is that, collectively, there is enough knowledge and expertise within the country's borders, right? It's just that the dissemination of that knowledge is not uniform. And it's a real pity if a patient in Bhubaneswar has a condition which a doctor in Chennai or Bombay or Kolkata might have seen several times in his career, but the local practitioner in Bhubaneswar has never seen that. It would be a real pity if the patient were to not be able to avail of that expertise, which is actually residing within the country's borders, just because of physical distance. And so really allowing sharing of clinical cases, allowing doctors who are more junior to consult their senior counterparts in a seamless manner is really one of the best ways, I think, to solve this problem of lack of expertise in the so-called hinterland.
Thank you. Suresh, I think we probably have a last question because I've taken some. I think one of the questions which has come is that while we've spoken a lot about what can happen, what is the actual deployment on ground, and how do you see that happen in the next 5 years? If you were to crystal gaze India and say, how will the healthcare system look in 5 years' time? What would be your top building blocks for that?
I think a lot, Rana, and what was mentioned is it is going to be driven by whether the self-pay model will move to a more co-pay model with insurance support. And I do think that behavior will continue to positively change given the pandemic and the overall center staging of healthcare in India. I think that would have a positive set of ramifications on everything that we're talking about in terms of healthcare and wellness adoption. I think even a lot has changed in terms of people thinking a little bit more about wellness. Hygiene, for example, has dramatically changed in terms of washing hands, for example. This is unprecedented in terms of change, and infection rates have significantly dropped, probably forever. In a country where that was one of the primary causes of death, right? So I think the next 5 years we'll definitely continue to see a positive trend on that, and that would mean that we're going to see greater incidence of the more lifestyle-like diseases, which was already growing in India, and cardio and oncology. Some of those will continue to be the bigger areas of concern or the burden of disease. I also think that, as you also mentioned, that digital payments and the fact that the mobile phone is more than just for making the call is now truly democratizing access to information, the ability to have, to be equal to somebody who is in a city where there is a large opportunity of meeting a specialist face to face. I think that will be a trend that will continue to exist. Combined with what Anirban said, I think there will be a need for people to trust and to see somebody in the flesh. So there is going to be more and more hybrid models that I see emerge in the healthcare delivery system. Not pure video and tele, but also not pure physical. And the combination of that will, I think, continue to exponentially increase. There's an opportunity, therefore, for consolidation and brands that will have to transcend the urban and the semi-urban / semi-rural areas. And I think that opportunity space is going to be accelerated. The consolidation in healthcare has already begun, and it will continue, in my opinion, in terms of utilization of the capacity that is sometimes too concentrated in the cities, and that will now have to move into the semi-urban for follow-up care, even for diagnostics, etc. So, I mean, there's a lot that I envisage in terms of change. I do think that healthcare has been amongst the slowest in terms of change as compared to, say, financial services or any other thing. And in many ways, thankfully, from a patient perspective, unfortunately, the pandemic had to drive it. But in many ways now, I do think that there are brighter days in terms of healthcare for especially developing economy like India.
No, thanks. And I think, in a way, it's catalyzed a lot of things, which just like the vaccine, we got it in 10 months. A normal development cycle would have been 10 years. A combination of both the funding, the regulatory, and the need for it. I think so. I think some of these lessons we've really learned can catalyze, because, like I said, we probably have to have a different model of healthcare which doesn't exist anywhere. If it succeeds, it's probably the Indian model of healthcare going ahead. I think we just have a couple of minutes left. Partha, one of the questions was asked about, if you're putting a new healthcare platform, there is a large geriatric population in India, which just not I wouldn't say they're technology friendly. The technology wasn't there at that time, and so they are our apprehensions. What have you done to make sure that gets addressed in your platform?
We have not focused on the geriatric population and such. We are focused on the mode of a primary health setup, low-tech areas. But I think that based on our observation, it can be extended into that population as well. And there could be many things like what Anirban was talking about, having a system which actually produces an alert and which gives an alert and talks to the what I will say that inform the local physicians or caregiver. That is a very useful system. Another thing which we traditionally do not see as a healthcare per se, but for any assisted living, if there are apps or that kind of model is available where that they can actually get an access to the caregiver or the ayas, for example, very easily. That is also very helpful in the urban setup. That's what I feel.
No, true, and I think a model which is very, very appropriate for each geography, each location, and really sort of empowers them to, both seek health proactively and also in a crisis. So I think we had a very engaging discussion, and I think there are many questions, and we could go on, but we're being very cognizant of time and for the next session. I think a wonderful thing about how equality will come using telehealth, how we should build on. Very interesting to hear what have been some of the experiences on ground, how the actual deployment is taking place, and how the government actually can facilitate this so that because I think health and education now are clearly at the forefront as we propel our GDP growth, and the ability of healthcare to be that engine of growth means that we need more people to be healthy to take that forward. So I want to thank all my panelists. I want to thank Anirban, Suresh, Partho for a wonderful panel, and look forward to seeing all of you next year. Thank you. Take care.
Thank you.
Thank you.
Thank you. It was a very enlightening session for me, our colleagues, and I'm sure for the participants. And it's evident from the questions we have received. So we are closing this session, and the next session would be on paramedics and how technology may empower paramedics. It would start from 3:15 p.m. IST. We'll close this session with a video of our partner.